et bienvenue. My name is Dr. Lynn Gillespie, and I'm a research scientist and section head in botany here at the Canadian Museum of Nature. Welcome to the third event in our series on brain health and wellness, Talk Brain. This series is presented jointly by the Museum and the Ontario Brain Institute. OBI has provided valuable expertise as the knowledge sponsor for our summer exhibit, Brain, the Inside Story, and the associated program like today's talk. As a natural history museum, we are continually looking at new ways to engage and inspire people about the natural world. And incorporating the story of humans into this realm is increasingly important. So I'm a botanist who studies plant biodiversity. And I can tell you that plants have an incredible array of compounds that can be used for medicinal uses. Indeed, we know that for millennia, humans have tapped plants for these properties. Many drugs are derived from molecules that were first identified in plants. Cannabinoids from cannabis are one example that you will hear about tonight. Current research is breaking new ground in the treatment of brain-related conditions. To tell you more about our speakers and the talks, please welcome Garth Smith, the Director of the Industry Relations at the Ontario Brain Institute. Je vous présente maintenant Garth Smith de l'Institut Ontarien du Cerveau. Garth.
Thanks, Lynn. Bonjour, hello, Ani. Thanks everyone for coming out tonight. My name is Garth Smith. I'm the Director for Industry Relations for the Ontario Brain Institute. The Ontario Brain Institute is a provincially funded organization that works to improve the lives of people living with brain disorders. We work with researchers, clinicians, industry, and patients across Ontario to ensure that our Ontario neuroscience excellence is translated into real health and economic impacts. The part of our role involves engaging the public so they have a better understanding of the brain and brain disorders. That's why we're pleased to partner with the Canadian Museum of Nature to present the brain exhibit. You should visit it. It's the Inside Brain Story, and the Talk Brain series. These are conversations on brain health in Ottawa. Tonight's talk focuses on drugs that are often used recreationally, yet have potentially important uses for the treatment of brain disorders. Ketamine for depression, and cannabis for epilepsy. There is also a fair amount of research and companies driving the development of LSD and psilocybin for other neurological conditions. So a lifetime ago, I used to work for a company that tried to incorporate THC, which is one of the active ingredients in cannabis, into a pharmaceutical. So this topic is near and dear to my heart. And I think that given the interest in this talk, perhaps the time for acceptance for the medicinal uses for these drugs is now. So after tonight's presentation, we'll have a moderated question and answer period. There will be an opportunity for you to ask questions. To do this, simply direct message your question to OBI via Twitter. And I believe the slide behind me will tell you how to do this. There will be one more public talk in our Talk Brain series on August 16th. We'll have the talk right here on estrogen and the brain. You can get more information and sign up to receive updates from us by going to our website at thebraininstitute.ca. Our moderator tonight is Dr. Zul Morali. Dr. Morali, I have to be patient here. Dr. Morali is the President and CEO of the Royal Institute of Mental Health and Research, affiliated with the University of Ottawa. He's also the founding scientific director for the Canadian Depression Research and Intervention Network, or CDRIN. He's a full professor in the faculties of medicine as well as social sciences at the University of Ottawa, and is a research professor at the Institute of Neuroscience at Carleton University. When does he sleep? I have no idea. Dr. Morali obtained his PhD in pharmacology at the University of Ottawa and is well known in his field to be an effective collaborative investigator and a strong critical thinker. Dr. Morali has published more than 20 book chapters and over 200 scientific papers. Dr. Morelli, welcome. Our speakers tonight are Dr. Erick Sell and Dr. Pierre Blier. Dr. Sell is a pediatric neurologist at the Children's Hospital of Eastern Ontario, or CHEO, and he's also an assistant professor at the University of Ottawa. Dr. Sell studied pediatric neurology and did an epilepsy fellowship at the Hospital of Sick Kids in Toronto. He's also the director for the Angelman Syndrome Clinic at CHEO and looks after children with drug-resistant epilepsy. Dr. Sell, welcome. Dr. Blier is a full professor in the departments of Psychiatry and Cell and Molecular Medicine at the University of Ottawa, and is the director of the Mood Disorders Research Institute, or unit, at the Royal Institute for Mental Health Research. In addition to his extensive list of publications and lectures presented worldwide, Dr. Blier has contributed to several treatment guidelines for psychiatric disorders. He has a basic laboratory investigating how psychotropic medications work in the brain. He carries out investigator-initiated clinical studies, and he treats patients with mood and anxiety disorders on a daily basis. Dr. Blier, welcome. So enough of the preamble. I'd like to ask Dr. Blier to come up and start tonight's talks.
Thank you. Bonsoir à tous et à toutes. Welcome, everybody. Thank you for coming here tonight to hear these two lectures. So I will start actually by using an example that everybody would be familiar with to address this topic. And it's the example of aspirin. Everybody knows about aspirin. So for centuries, actually, willow bark leaves and leaves were used to treat fever. And actually, what was the active ingredient is from a plant, and it was aspirin. So it's been synthesized in the 1800s and used to treat fever, for example. But it's not until the 1970s that its properties on inflammation were discovered, and also its anticoagulant properties. So now, for example, when somebody is suspecting of having a heart attack, before you do anything, you make them crunch an aspirin because it has an immediate effect. It's rapidly absorbed. So you see a product that's been around for decades or even centuries still find its way in our most recent guidelines for something different in medicine. And as was mentioned by Garth, today I'll be speaking about ketamine, which is yet another example. So ketamine, or Ketalar, was introduced in 1963 as an anesthetic agent. So in so doing, it produced profound analgesia, amnesia, and it does not decrease breathing or other cardiovascular parameters. So that's why we call it basically a dissociative anesthetic agent. So it's been in use for 45 years. So Garth mentioned some people abusing this medication, but for 45 years it's been used in the clinical setting by our professionals. And it's still being used on a daily basis in our operating rooms all over the world and here in Ottawa. For example, I had eye surgery twice last year, and that was one of the components of the anesthetic mixture. So it is commonly used. So it's been used more recently, actually since the early 2000s in depression. And just to highlight the features of this psychiatric disorder, I think it's important to mention that 1 in 6 individuals will suffer from a major depressive episode in their lifetime, which would require pharmacological or intense psychotherapeutic treatment. And currently, the prevalence of depression is about 5%, so 1 person in 20. So these are huge numbers. And one of the catastrophic outcomes of depression is suicide. And we have the statistics always with a certain time lag, but between 2011 and 2015, the rates have been increasing by 13%. So in 2015, for example, there were about 4,200 suicides. That's like the equivalent of 20 major plane crashes only in Canada. In contrast, in other areas, we've made great progress. Number of deaths on the road has decreased quite markedly, and it now stands at about half of the deaths that are encountered by people who die by suicide. And worldwide, it's estimated by the World Health Organization that about 800,000 people die every year from suicide. So just do the math. It's like wiping out the entire population of Ottawa every year on a global basis. So it's a huge problem. So what about medications to treat depression? Well, the classical medications that you may be familiar with, like the Paxil, Prozac, Effexor, and so on, when we start giving them to patients, it generally takes, if they're going to work, it takes about 2 weeks before you see an onset of action. And if they work, it's going to work after a delay of 6 to 8 weeks. So that's an incredibly long delay for somebody who is suffering. So ketamine has been used, like I said, over the past 10 years or so at very low doses, and was shown to produce in a significant proportion of individuals a marked antidepressant action, but not within 2 to 3 weeks or 6 weeks, but often within 24 hours. And importantly, that's low doses, it's subanesthetic, so the blood levels achieved when we perfuse the ketamine intravenously is about 10 times lower than what you get or what you need to have anesthesia. So it's very low doses, and you can see an effect in some individuals after a single infusion. And I'll show you some results from our own studies, but actually you can sustain this augmentation, this strategy, in addition to medications, if you give it actually repeatedly. So we've just completed this study at the Royal in 44 patients who first underwent what we call a double-blind crossover. So that means they could be allocated to receive ketamine itself or another agent which produces some mild dissociative effect, or in this case midazolam, another agent that's used for anesthesia. So as you can see on this slide, when the midazolam was given, that's the green line, there was basically no difference. So these were patients who were suffering from depression at a very severe level, and basically nothing happened after 2 hours, 24 hours, or 7 days. However, when the patients were receiving ketamine, there was a significant detectable effect after 2 hours and after 24 hours, and that basically seemed to go away. So, but not everybody responds, and those people who got a 50% decrease of the intensity of their symptoms, well, they went from a severe condition basically to almost remission. So it's a score of 10 on this scale would represent almost a normal condition. And this seemed to be fading away over time. So if the people tolerated the procedure, and basically only 2 of the 44 patients dropped out because of side effects, they went on to receive 6 infusions over a period of 2 weeks, so Monday, Wednesday, and Friday. And at the end of these 2 weeks, then we separated them into people who had a 50% or more improvement of their condition, and those who did not. So in the people who did not have a response to treatment, as you can see, their intensity of their symptoms in general did not change, but those who presented a response actually also had a significant decrease of their symptoms. So they were less sad, they were able to concentrate better, and their appetite had recovered, and they were sleeping a lot better. So what's important in our study here is that this major improvement did not occur over 6 to 8 weeks, but over a period of only 2 weeks. So some people responded well after 1 infusion, and some people it took 2, 3, 4, or so on. And so basically, we should not be giving up after giving a slow infusion like that with the first trial, because initially we saw about 25%, a quarter of the people having this robust response, but doubling the number of responders over a period of 2 weeks. So this is actually quite striking. But one of the most important things is that it also had a major impact on suicide thinking or ideation. So here what you see on this graph in the green bars are the people who had almost no ideas of thoughts of death or of suicide. The blue column represents people who had moderate intensity of suicidal thinking, and the red, people with very intense suicidal thinking, and some of them even having a plan. So after a single infusion, you can see that we went from 16 patients who had important suicidal thinking, and that was cut by half. And as we continued over time, we're left with only 3 people here where there was no effect on suicidal thinking. So most of the people actually had a significant decrease in suicidal ideation. You see the number of people really losing these thoughts of death was markedly increasing over this 2-week period. So in summary, take-home messages is that ketamine, so an agent that's been used for over 45 years in the medical field, can produce a significant decrease of depressive symptomatology, maybe about half the people who were very ill and treatment resistant, meaning that they had failed several other medications before. So 80% of the people had a decrease in suicidal ideation. And so it does produce some mild side effects, so people feel a bit loopy, as some describe it. But these side effects go away quite rapidly, generally within 15 to 30 minutes. And very importantly, our patients were people who did not have a history of drug abuse in the past. So if they did not receive this treatment. And nobody in our experience so far has been craving this medication, trying to, say, obtain it outside of our clinical setting. So with respect to the future of retooling ketamine, so ketamine is something that is available but is not approved yet by health regulatory agencies. However, we have participated in a multi-center, multinational trial where a new form of ketamine was used by intranasal inhalation, so much easier to administer. And the trials have been successful not only in the acute treatment, but also in the maintenance over several months. And so the company producing this preparation of ketamine has gone to the FDA and hopefully should be commercially available within 1 year. And not only is ketamine and a derivative effective, but from a better knowledge of the mechanism of action, newer substances are being developed with less side effect and perhaps greater efficacy. So I think, and I hope I've convinced you that yes, we do need medication to treat our patients more effectively, but sometimes a solution may be just in our backyard and maybe in front of us. So I think by clarifying mechanisms of action of medications that we use in medicine, then we can treat more people successfully. And I will stop here and thank you for your attention.
So I'm hoping to give you now a clinical view on the use of cannabinoids in pediatric epilepsy. I'm a pediatric neurologist. I have some experience in assisting researchers, but the view that I'm going to show you right now is a little bit more focused on the clinical experience over the last 10 years. So I have, as most pediatric neurologists, a large number of patients that unfortunately suffer from epileptic seizures that cannot be controlled fully by many available anticonvulsant medications. And this accounts for about a third of all patients. This hasn't changed that much over the last decades, despite a number of new medications in the market, which, as you can understand, is quite frustrating for families and physicians. I'm going to start with a brief history of cannabis. And cannabis is a derivative of the marijuana plant. And marijuana has been with the human beings used in many different ways since at least 5,000 or more years ago. Apparently, the story can be traced to China in about 4,000 before Christ, and from there, its use propagated into the rest of Asia, Africa, Europe, and then to the Americas. There are some scripts from Chinese textbooks specifically describing recipes and the use of cannabis. Now, the marijuana plant, keep in mind, has been used as hemp for its fiber, and it was in industry up until the 1930s, when a lot of stigma developed due to the recreational use of marijuana. So what I'm going to talk to you more is not really about recreational marijuana. So I'm not going to go into marijuana as a whole. It has more than 450 elements in it. I'm just going to focus specifically on its medical use and more so on CBD. For many years, it was marketed for treating different problems, including pain, muscle spasms in multiple sclerosis, and it is still used for this reason. It is used for nausea in patients with cancer, and more recently, but not for the first time, in intractable epilepsy. So how does it work? Well, we know, just looking as an observer, following the individuals that consume cannabis oil or high percentages of CBD, is that it can have different effects depending on which part of the brain the receptors are stimulated by those molecules. So it will have an effect on the cortex, where we intend is going to suppress certain networks that increase and propagates epileptic seizures, but it will also have some effect over the limbic system, sometimes decreasing anxiety, sometimes increasing alertness. And this is not a surprise that an effect over the basal ganglia has been used or targeted specifically to control movement disorders. So there's always a chapter in history that revives the interest in an old drug for new uses. And I think that probably the story of Charlotte and Charlotte's Web is what boosts a lot of interest in medical marijuana for refractory epilepsy. Charlotte is a young girl that was diagnosed in early life with a catastrophic form of epilepsy called Dravet syndrome, for which medications don't tend to work well. And after exhausting many medications and after recommendations by relatives, she was given a specific breed of cannabis plant that had a very high concentration of CBD oil compared to the THC, which is the molecule or the ingredient of the marijuana plant that has the effect of making hallucinations or making the person feel high, let's say. So she she did not become 100% seizure-free, but her quality of life improved very significantly. There was a drop of seizures that was sustained with more alertness and overall a great improvement in quality of life. And many other families learned about Charlotte's story. The company that was producing this type of plant specifically named the plant after Charlotte because of her success, and it's called as Charlotte's Web. So a lot of times you'll hear families asking, how do I access Charlotte Web cannabis oil rather than other brands or other oils? Now, this is where I start to involve myself. So what happened is I would meet families that would receive cannabis plants in different ways, sometimes legally delivered by growers, but then they had to process them by themselves. They would have to let them sit in oil or in coconut oil, and then without knowing too much how much they were delivering, they were trying to do their best to dose it for their children. So this has very, very quickly evolved, and now we have preparations that are already establish a ratio of high CBD to THC. I can tell you that I've been witness of almost no significant side effects, so it has proven to be fairly safe, and children definitely don't get high, they don't start hallucinating. Keep in mind, it's not the same as marijuana plant. It's a very specific compound. And now there are some synthetic forms that have been marked and approved by the FDA for this use. So very quickly, what CBD will do is what other medications do as well. I use this slide as an example of a drug called Nabilone that help us to illustrate, to trace how it gives sort of a negative feedback from the brain cell extension that is trying to stimulate another nerve cell. And after a message is received, it triggers a message that is delivered to the initial producer trying to decrease the next route or the next delivery of that neurotransmitter. So in other words, it tries to cool down the excess of neurotransmission when that neurotransmission is excessive. So some final thoughts on cannabis, and I'm going to finish quickly because I'm sure that you probably will get more from asking questions than listening the rest of the story. But just like it is promising, and there's a lot of role for cannabis and research, I always emphasize that it appears to be already as another option for treating epileptic seizures, but not necessarily a superior one. And with that, I'm going to finish like we started with this tree, which is the willow tree, where aspirin comes from its bark. And thank you for your attention.
So there was a fascinating expose on how all drugs are coming into market with new uses. And it's your opportunity, if you have any questions, to ask. There are cue cards going around. You can write your questions, and we will be able to ask the speakers. Or you can even tweet the questions, and they'll come around to me, and then I'll, on your behalf, ask some questions. So whilst you're doing that, thinking about some of the questions, maybe we can begin talking about questions to Dr. Sell. And is cannabis more effective at controlling seizures than other anticonvulsants, you think?
No, I think that it is another option. So it is the way we see it, and I think there's very good evidence from Dr. Devinsky, who is a pediatric neurologist in New York, who has done most of the studies, including placebo-controlled studies, showing that it definitely has an anti-epileptic effect or anticonvulsant effect, but it doesn't seem to be necessarily superior than other medications. We see it as another option, an option that sometimes has a benefit of less side effects or different side effects, but it wouldn't be fair to say that it is superior or that it has no side effects, because we do see sometimes liver enzyme elevations and gastrointestinal side effects.
Okay. Dr. Blier, in terms of your fascinating work with ketamine, it's quite exciting to see that now we have drugs that can treat depression within hours, or at least alleviate symptoms of depression within hours, rather than days or weeks. And so that's really, I think it's a huge step forward, because I think it's been 40, 50 years since we have had such a substantial change in the time frame of the drug action. And I'm wondering, one of the things that you mentioned was that you need to give ketamine repeatedly, I guess because the effects of ketamine don't last too long on a single infusion. I'm wondering, does tolerance develop to repeated administration of ketamine?
No, actually, the short answer is that if it works once, it's going to keep working. So we do have to give it repeatedly, because the effect will fade away. In some patients, it may take 3 days to fade away. Some patients, it will last for 3 weeks. But we do have to give it repeatedly. And this is one very striking difference, because what happens in the treatment of depression is, unfortunately, a lot of patients stop prematurely their medication. And when they relapse, if they stay in a relapse state for too long, we may reintroduce the same medication or combination of medications, and it may not work again. So far, we've not seen that with ketamine. Some people have relapsed, and when we give it, it keeps working. So that's a very encouraging thing to see, and it's also guiding our research, so to try to see what explains the fact that there is no tolerance to this product.
Mm-hmm. Thank you. A question from the audience is that if the patients on ketamine, were they given other antidepressants whilst they were getting ketamine?
As I briefly mentioned in my presentation, the people who entered this study were highly treatment resistant, so they had failed 3 medications and 3 combinations on average. So they were quite ill, and we maintained whatever medication that they were on, or medications, because we wanted to do only one thing at a time, and it's to give the ketamine. So we did continue these medications. And actually, from the studies of repeated administration, it seems that with some people, you're able to maintain. So you don't necessarily have to give ketamine repeatedly if you maintain the other treatments.
Thank you. And to Dr. Sell, one of the questions that came up was in terms of the use of cannabis oil, because it's extracted from a plant and it contains many different compounds. It may be high in CBD, but what are your thoughts about interaction between compounds that are within that family, within that plant source?
Yeah, so it has probably 2 ways to be looked at. One is that there's definitely interaction with at least anticonvulsants. When a patient is taking benzodiazepines, so like Valium or such, the levels can increase. The cannabis seems to potentiate the effect of benzodiazepine, and with other medications that can elevate the liver enzymes, that can also be a problem, because we already tolerate a certain elevation of liver enzymes with some medications. So if you combine cannabis and that elevation increases further, that can be a difficult interaction. At the same time, there are many families that have tried cannabis oil versus Epidiolex. Epidiolex is the synthetic form, let's say, or the most purified form that has been developed for medical cannabis for epilepsy, and they didn't experience the same reduction of seizures. Their rationale is that there might be more than CBD to the control of epileptic seizures, and that has proven to be the case with some patients that have used higher ratios of THC, not to the point that it becomes regular recreational marijuana, but more than purified CBD, and they have obtained better seizure control in some cases.
Okay, thank you. One of the questions from the audience is that from your clinical experience, what proportion of treatment-resistant children respond to CBD treatment?
So I'm going to quote these studies by Dr. Dravinsky, and you can summarize them in a third will have a very observable, noticeable report of seizure reduction. A third will obtain some benefits that are maybe not superior than placebo, but some benefits by reducing other anticonvulsants or better alertness. And there is 1/3 of those patients that definitely will not have any benefit at all with CBD oil.
Thank you. Dr. Blier, does ketamine have side effects, and does it work on patients who have consumed antidepressants for many years?
So when we infuse ketamine, we do that over a 40-minute period, and like I said in my presentation, the patients can experience side effects, and they may feel a bit separated from their environment. They may have a little bit of visual distortion. They may become more sensitive to sound, but it's generally mild. And so we give a fixed dose on a milligram per kilogram basis. And so when we limit the absolute dose to about 50 milligrams maximum, these side effects are generally quite mild, and they go away rapidly. Now, with respect to long-term side effects, we've not seen anything. There's, for example, no decrease in cognitive function, as can be the case, for example, when we treat these severely ill patients with electroconvulsive therapy. So nothing seems to come out, and I'm really not surprised because we've had this medication for 45 years and it's been used worldwide. So I feel pretty good that the patients are safe when they receive repeated ketamine infusion, the pure form, under medical surveillance. Now, you may have heard of some people abusing it on the street where they can have actually bladder obstruction. But these are people who abuse and they take really massive doses. And we're talking here about 15,000 milligrams per week versus 50 that we perfuse intravenously. So it's completely two orders of, markedly different orders of magnitude.
Mm-hmm. I have quite a few questions here. People curious about, you both mentioned FDA approval of some substances, which is more American. What is the scene on the Canadian landscape?
Well, unfortunately, Health Canada is usually slower than the FDA, and there's usually a significant delay, for example, in my field with approval of antidepressant medications. So in the FDA in the United States, their workforce is greater and they have more consultants, so they can proceed more rapidly. So I just wish Health Canada was moving faster to approve medication, and we'll just have to see with the S-ketamine. Mm-hmm. It's probably going to be available first quarter or fourth quarter of 2019. We'll see how long it takes in Canada. So hopefully with such nice results, it should be approved faster.
Yeah, I completely agree. And there are, again, it's not for lack of evidence. One of the things that we have to live with in the case of cannabis oil is that is not covered. So a lot of the families, or actually all of the families that do want to have use of that product, they're going to have to pay for the oil from pocket, right? So it's not covered.
So in terms of using the oil or instead of the pure extract or pure compound, what are your thoughts on that? To use a synthetic CBD rather than a plant extract that contains CBD and other constituents from the plant?
I think I'm very positive that all colleagues would feel more comfortable prescribing a pharmaceutical proven compound because it's going to facilitate also the dosing.
Mm-hmm.
The problem is that, yeah, it is approved and available in the United States. We don't have it yet approved in Canada.
Mm-hmm. That's interesting because at the Royal we're just about in the process of maybe launching a clinical trial looking at the effectiveness of CBD and THC in treatment of PTSD, for example. But we will be doing experiments on the pure compounds rather than the marijuana plant, because the marijuana plant can be so variable depending upon the strain you get.
Can I just add to what because you alluded to the cost. And with respect to ketamine, if it's allowed to go on the market and expand more, costs to the healthcare system should drop quite markedly in that population. And this is because a little vial of ketamine that we can treat about five patients costs only about $30. So most of the cost goes to the perfusion line and the medical staff to supervise. So if you compare the cost, and that's what we hope to show, is that when you compare the cost of ketamine versus the cost of an electroconvulsive treatment, it would be much lower, because when you give the electroconvulsive therapy, you have to have an anesthesiologist. It has to be done in the hospital setting. You have to have a psychiatrist, and you have to have the nursing staff. So we hope to be able to actually cut the cost to the healthcare system.
Thank you. So that's very interesting. So one of the questions I have is that, are there any clues as to who will respond to ketamine and who will not?
Well, whether it's ketamine or antidepressant medications, we have good negative predictors. So that's if it doesn't work after 2 weeks, it's not going to work. But everybody is seeking a positive predictor of response, so that we would immediately go to a certain type of medication, or go to ketamine, or go to ECT. So actually in Canada we have a fairly large group called the Canadian Biomarkers for Depression, where we're looking at different modalities of treatment, whether it's the regular serotonin reuptake inhibitor, the augmentation strategy, the transcranial magnetic stimulation, and so on. So we're all working on that to try to get a predictor of positive response, so that we could cut the time and go straight to what we think is going to work.
Mm-hmm. One of the questions is that the traditional antidepressant drugs have some side effects that are not very attractive to young people in particular, like sexual side effects or effects on food intake, gaining weight. How does that compare, traditional antidepressants versus ketamine? Is there evidence whether it impacts the same functionality or not?
Well, so far with ketamine, because of its extremely duration or presence in the bloodstream, it doesn't give prolonged side effects like weight gain or sexual dysfunction. So it's basically eliminated completely within 12 hours from the system. So it doesn't give protracted side effects. So we always use the ketamine, or the S-ketamine that's in development for commercialization, is always with antidepressant. But there probably will be a day when we could use ketamine by itself, so we wouldn't have to deal with the other antidepressants. But I think it still remains a good clinical skill to try to pick a medication that will have minimal side effects, and it's usually possible to do so in patients.
Mm-hmm. So the other question I had is that in terms of the use of cannabinoids in treatment of epilepsy, for example, what do you see in your horizon as the other applications that may be, since marijuana is going to get legalized, and especially from the medical side, what other uses do you think might come to fore?
Yeah, well, I think that there's probably many uses, because there has been historically many uses, even before like organized civilization, right? So interestingly, I think that our drugs overlap, because we use ketamine, for example, for refractory epileptic seizures in the intensive care unit. Patients will get sometimes probably different dosing, but so I guess it's a proof of concept that what we were talking, that sometimes you don't need to look for a new compound or a new molecule, just need to understand something that is already available, that has proven to be safe, that has proven to be useful, and find other uses for it. So what I see for cannabinoids is that hopefully, because it has probably still a lot of stigma, that hopefully with the legalization of marijuana as a recreational use, that is not going to prevent the further research and development of some of the cannabinoids for uses like epilepsy, but also pain, also cognitive function, why not depression, anxiety, sleep disorders. And it's being used already. There are synthetic forms of cannabinoids that have been in the market for many, many years. Like I was showing early, for some forms of chemotherapy to treat some forms of cancer. So I think that as long as it doesn't go like many other compounds, that there was so much stigma that nobody decided to research them further, and then they never got properly used.
Thank you. So it looks like we're running out of time. So in closing, I'd like to say that, first of all, thank you all for attending. I know many of you had a hard time getting here. I know I did. I for a while, I thought I was not going to make it here. The traffic is just horrendous today. But what we have learned a lot about some true cutting-edge discoveries that are going on, and I think that it speaks to the fact that we've, as a communities, try very hard to conserve our forests, because it is so many offerings that we might find new and additional drugs that might not necessarily come strictly from the lab, but might come from the shamans and might come from the plants and extracts. But it sheds more light into how we can use that information to develop new targets and new treatments and new drugs. So that's really quite exciting and worth fighting for, I think, in terms of conserving botanical diversity that we have inherited. So these old drugs having new uses, I think that's going to continue happening, and I think that we'll find more and more along those lines. I think that if there's one thing that we want to, that maybe a take-home message would be, that the knowledge is that there is no such thing as illicit drugs. It is really illicit use of drugs, because we have all kinds of drugs, for example, the opioids that are very powerful in treating pain, but if you abuse it, it's lethal. And so similarly, we use cocaine for surgeries of the eye, and been doing it for years. But if you use it as a street drug, it's a different usage, and so on and so forth. So I think that it's really, we have to tread the line very carefully, but we should not be throwing the baby out with the bathwater, as they say, because there's a lot of very powerful and very useful medications that come from nature. So effective therapies. So I'd like to extend a big thank you for all you participants coming here, and the speakers for having taken the time to present, develop a talk to share with you. I'd like to thank the Canadian Museum of Nature, the Ontario Brain Institute, of course, the Epilepsy of Ottawa, CHIO, the Royal Institute of Mental Health Research with the University of Ottawa, and of course, our two speakers, Dr. Blier and Dr. Erick Sell. So thank you very much, and thank you. So for those that are interested in watching a replay of this series, there's information on the bulletin board, on the slide behind me, because it's going to be publicly recorded and played back, so you can revisit if you wanted to. But I also encourage you to attend the final installment of the Talk Brain series here at the Canadian Museum of Nature on Thursday, August 16th. They're going to be talking about estrogen and the brain. It will be presented by Dr. Gillian Einstein, and will be moderated by our old friend Andre Picard. So if you're interested, you can come back here and have another installment of exchange of information. So thank you very much.